Okay, starting with GI, gastrointestinal tract. First, I will discuss dyspepsia, ulcers, then GI bleed. Then I will go with diarrhea, types of diarrhea, inflammatory bowel disease, irritable bowel syndrome, and then dysphagia, and then hepatobiliary system, acute pancreatitis, and other things. Okay, so this way I will go. So starting with dyspepsia. So what exactly is dyspepsia? So it's basically patient comes to you with I have a doctor, I have a slight pain in the upper part of my belly. So the patient will have I feel nauseated whenever I eat something, or throughout the day I feel nauseated, like I feel like I will throw out, and the patient has abdominal bloating. Okay, and it is different from GERD or irritable bowel syndrome. So this is the criteria for dyspepsia. As you can see, patient will have postprandial fullness, like patient eats something, he will feel full. Even slight intake of food, he will feel full. Early satiety, okay, epigastric pain, burning, and there is no evidence of structural disease. And the symptoms have to be present for at least 3 to 6 months. Okay, so that's for dyspepsia. So these are the symptoms which are present in dyspepsia. Okay, so the patient comes with these symptoms. What are the things which come in our mind? Uh, Like these are the causes of dyspepsia, and the most common cause is functional dyspepsia without any cause. Okay, there are no organic causes. So, which is the main cause? Or the patient may have GERD, gastroesophageal reflux disease, a peptic ulcer disease. There may be some ulcer, or the patient took some drugs like NSAIDs, bisphosphonates, antibiotics, potassium chloride, iron tablets. Okay, that they can also cause discomfort. Malignancy can also cause. Okay, so there is a huge list of drugs is given. You can just have an idea. You don't have to remember all of these, okay? Just have an idea, few of the drugs, okay? Hyperkalemia, hypercalcemia, giardia, these are not very important. Just have an idea. So these are the various causes of dyspepsia. Okay? The main cause, as I said, it is functional and it occurs because of H. pylori infection. And when we give the patient antibiotics to relieve this H. pylori infection, the symptoms will get relieved, okay? So the patient comes to you you have to make sure that suppose the patient is less than 55 years of age. I will come to that. Patient is 40, 45 years of age, 35 years of age, whatever. Okay, and the patient says, I have whenever I eat something, I feel full, and there is a nauseated feeling. I have pain also, and I have burning sensation. So the first test you will do is H. pylori infection. And there are mainly two tests for H. pylori. We have stool antigen test and the urea bus test. We'll go for stool antigen test because it is more accurate. Okay. So these are the various causes of dyspepsia, as you can see, and the main cause is H. pylori. Okay. Sorry, it means this patient is H. pylori negative. But if the patient is H. pylori positive, the patient is negative. But if the patient is H. pylori positive, he can have this infection can lead to various things. I will come to that. It means it can cause gastritis, and this gastritis can lead to ulcers, and also the patient can have a maltoma, low grade maltoma. Okay, so this, and also it can cause cancer even. Okay, so this is for H. pylori positive. Okay, so the patient suppose has H. pylori infection. The patient comes to us. He is 35 years of age, and he has this abdominal bloating and early satiety and pain. Okay, so we conduct this stool antigen test, which is more accurate, and we find that the patient is in fact H. pylori positive. Okay, so this can cause inflammation leading to gastritis, and it can lead to atrophy and also intestinal metaplasia, in which normally the stomach has squamous epithelium. Normally, the stomach has squamous epithelium, and in case of metaplasia, it will be replaced by intestinal columnar epithelium. Okay, so there is metaplastic changes elsewhere in the body also, like in cervix, in case of lower part of the esophagus because of chronic GERD. I will come to that. Okay, so the patient has Barrett's esophagus, so these things occur everywhere in the body. Okay, so this metaplastic changes can ultimately lead to dysplasia and then cancer of the stomach. Okay, so this is the way it occurs. Like the patient may have a chronic gastritis, and this gastritis can lead to inflammation. Means there is inflammation, chronic gastritis, and if it persists, it may lead to duodenal ulcer. If it is at the antrum, and in some of the cases, it can lead to gastric ulcer. Okay, so always remember, gastric ulcer, it is the only means we have peptic ulcer disease. I will come to that later. We have peptic ulcer disease. So this peptic ulcer disease, it can be either gastric ulcer or duodenal ulcer. Okay, gastric ulcer or duodenal ulcer. Now only gastric ulcer, it is associated with cancer. It is associated with cancer. Duodenal ulcer will not be associated with cancer. Okay, so if you find gastric ulcer any, then the next step will be biopsy, because we want to rule out cancer. Okay, this thing also is important. I will come to that later. Okay, so this is a means the this is how chronic H. pylori induced chronic gastritis can proceed. Okay, but in most of the cases, there is a relief. Okay, in 85% of the cases, as you can see, there is no gastric disease. Okay, so this ulcer, duodenal or gastric ulcer, it occurs in very few of in 10 to 15% of the cases. You don't have to remember 10 to 15. They will not be asking. Just remember, in most of the cases, there is relief. There is just gastritis. Okay, and as you can see, it can lead to maltoma also. H. pylori infection, low grade maltoma. So this is the root of infection: atrophy, intestinal metaplasia, dysplasia, and gastric cancer, which I just told. Okay, if the infection persists, so there is atrophy, then intestinal metaplasia, in which squamous epithelium is replaced by columnar, and then dysplasia, and then ultimately gastric cancer. Okay. So wherever you think that these are slides are important, you can take screenshots. Okay. Clear? Any questions up till now? 14 days. Okay. Don't have to remember this duration. And if there is no relief by this is called triple therapy. Okay. And if there is no relief by this triple therapy, we'll go for quadruple therapy, which includes bismuth plus tetracycline plus metronidazole plus PPI. So everything is given in the notes. Don't have to write anything. Whichever if you have to write, I will let you know. Okay. So we have either triple therapy or quadruple therapy. Okay. So we are using amoxicillin plus clarithromycin. Amoxicillin plus clarithromycin plus PPI. So this clarithromycin is used for in any which other condition? Can you tell me? In which other condition we use clarithromycin? One is in triple therapy. In which other condition we use clarithromycin? So clarithromycin is used in case of MAC infection. These things you have to remember. In case of MAC infection, we give the patient Mycobacterium avium complex infection. Patient is HIV positive, so this is an opportunistic infection, and we will give the patient clarithromycin plus ethambutol. Okay. Okay, so the patient comes to us with dyspepsia. We go for the stool antigen test. It is found to be positive. So we give the patient to prevent any further infection, to prevent any complications, like the patient may have gastritis or low-grade maltoma, or the patient can have ulcers. Okay, so to prevent this, we give the patient triple therapy for 14 days. Okay, and if there is no relief, we go for quadruple therapy, which includes bismuth plus tetracycline plus metronidazole, and of course PPI. And if the patient is allergic to amoxicillin, we give the patient metronidazole. Okay. Now we have the patient comes to us again. I have relief of symptoms. Thank you very much. So then we will confirm that the patient has in fact there has been eradication of H. pylori, and eradication of H. pylori will be confirmed by, again we'll go for this stool antigen test. Okay. And if there is no relief, like the patient comes to us and I don't feel any relief, then we will go for upper GE endoscopy. So this is the protocol. So we are assuming that the patient is less than 55. If the patient is more than 55, then there is a separate protocol where then we go for upper GI endoscopy directly. So the patient, we are assuming that the patient is less than 55 years of age. Okay, and the first step is we go for stool antigen test. We treat the patient, and the patient feels relieved. Okay, and then we will again go for stool antigen test to confirm the eradication. Okay, but if there is no relief, we will go for upper GI endoscopy. Okay, so this is the protocol. If H. pylori testing, this stool antigen test, it is positive, I will let you know the protocol. Okay, suppose this stool antigen test, it is negative. Patient comes to us, patient is less than 55 years of age, and now we do the stool antigen test with dyspepsia. We do the stool antigen test, it is found to be negative. In that case, we give the patient PPI, proton pump inhibitors, for 4 to 6 weeks. Okay. Okay, and if there is no relief, we go for upper GI endoscopy. Clear? Any questions? So this is the protocol we follow. Less than 55 year of age patient comes with dyspepsia. We will go for stool antigen test. It is positive. We treat the patient. Okay. Patient says, I'm relieved. Thank you very much. We will go for again stool antigen test to confirm that the eradication. Okay. But if the patient is found to be H. pylori positive, and we give the patient therapy, triple therapy or quadruple therapy, whatever, but still there is no relief. No relief. Okay. Then we will go for upper GI endoscopy. And this is the case if the patient has H. pylori, is H. pylori positive. But if the patient is H. pylori negative, then we will go for means stool antigen test, it is negative. Okay, so then we'll give the patient PPI for 4 to 6 weeks, and if there is no relief, we go for upper GI endoscopy. So this is the protocol we follow if the patient is less than 55 years of age. Okay. Now, if the patient is more than 55 years of age, or the patient has alarming symptoms, like alarming symptoms include weight loss or dysphagia or dinophagia, vomiting, or the patient has hematemesis. Okay, in that case, like the patient is more than 55 years of age. Okay, the patient has dysphagia or dinophagia. Okay, anemia, weight loss, hematemesis, whatever, or black stool. So these are alarming symptoms. In that case, the first step is upper GI endoscopy. Okay, clear? Patient is more than 55 years of age, or any of these. Okay, so this is the protocol we follow. So this is a like a simple way. Slightly they have made slightly complicated actually. So you just have to remember this main. age more than 55 or alarm features, we go for esophagogastroduodenoscopy. That is upper GI endoscopy. It's upper GI endoscopy. Esophagogastroduodenoscopy. And if the patient has if the patient is less than 55 years of age, we can go for H. pylori testing and treatment. If it fails, then straight away we go for this thing, duodenoscopy. Okay. And if H. pylori testing is negative, suppose we give the patient PPI trial. If it fails, esophagogastroduodenoscopy. Okay, clear? Okay, so we coming back to dyspepsia again. I told the most common cause is functional cause, and there are other causes also, like drugs can cause dyspepsia. So the patient NSAIDs, basically they can cause dyspepsia. So NSAIDs, they cause dyspepsia by two mechanisms, basically by direct toxic, by either direct toxicity, like we give the patient aspirin. Okay, so this aspirin, it will cause aspirin or any other drug, NSAID. Okay, so it will cause a direct damage to the mucosa of the stomach. Okay, so the patient will have the symptoms, abdominal pain. Okay, or NSAIDs will cause uh, they will cause prostaglandin inhibition. So either direct toxicity or they cause prostaglandin inhibition. Okay, so there are two mechanisms, basically, like two pathways. So like we have arachidonic acid pathway. So as you can see, we have this arachidonic acid pathway. So it has it either forms leukotrienes or it forms these thromboxane, prostacyclins, or prostaglandins. Okay, so aspirin or NSAIDs, they inhibit this cyclooxygenase pathway. Okay, so there will be decreased production of prostaglandins. There will be decreased production of prostaglandins if we give the patient aspirin or NSAIDs. Okay, so prostaglandins, they have a protective effect on the mucosa. They have a protective effect on the mucosa. So they increase prostaglandins, they increase mucus production, they cause increased bicarbonate synthesis and also epithelial proliferation. Okay, so these are the effects of prostaglandins. Okay, so if NSAIDs, they inhibit NSAIDs or aspirin, if they inhibit prostaglandin synthesis, the patient will have decreased mucus production and the patient will have decreased bicarbonate synthesis and also epithelial proliferation. Okay, so NSAIDs will, they are exerting their mechanism, they are exerting their toxicity by two mechanisms, either by direct damage to the mucosa or because of decreased prostaglandin synthesis. Okay, so that's why even if we the patient cannot take orally, suppose any drug, we give the patient enteric coated tablets. Enteric coated tablets. Okay, so they can also cause damage to the mucosa. They can also lead to ulcer formation because of the inhibition of prostaglandin. Okay. So, this is also important. Like, suppose the patient has ulcers or the patient has gastritis, whatever. Patient is older, the patient has gastritis or whatever. Okay, and we have to give the patient NSAIDs. We have to give the patient NSAIDs. We cannot avoid. Patient has severe rheumatoid arthritis or the patient has SLE, whatever, and the patient has ulcers also, whatever. Due to whatever reason, we have to give the patient NSAIDs, and the patient has ulcers. So in that case, we can give the patient combination of, we can give the patient PPI also. So these PPI, even if taken with NSAIDs, if these PPI, even if taken with NSAIDs, they can cause healing of the ulcers. Okay, and they can also prevent progression of the disease. Okay, they can cause healing of the ulcers, and they will also prevent this further progression of this gastritis. Okay, so we can, if we cannot avoid these NSAIDs, we can give the patient PPI. Okay. There are other drugs that can also be given, but this thing also we can do, or we can go for COX-2 inhibitors also, like celecoxib. But you have to take special permission for using celecoxib because they causes cardiovascular diseases. Okay, clear? Any questions up till now? Okay, so this is one of the NSAIDs or any drugs. This is another cause of dyspepsia. Okay, so another cause of dyspepsia can be ulcers due to any cause. Whether it means H. pylori infection is the main cause, but there can be other causes also of ulcers. Uh, so as I said, the patient can have gastric ulcer or duodenal ulcer. Okay, so dyspepsia will occur, nausea, vomiting, okay, belching, and sharp burning pain. Gastric ulcer will cause pain in the epigastrium, left of the midline, and duodenal ulcer mid to right of the epigastrium. Don't have to remember. I mean, generally they cause pain in the epigastrium, either gastric or duodenal ulcer. Okay. Now, the pain of the duodenal ulcer, it gets relieved with eating due to release of bicarbonate-rich secretions, and the pain of gastric ulcer, it gets aggravated by eating. Why? Because there is release of acid. Okay. Whenever we eat something, there is release of acid. Okay, in the stomach. So if the patient has this gastric ulcer, this is important. Okay, if the patient has this gastric ulcer, the patient will say, whenever I eat something, I have aggravation of the pain. So this is a comparison between gastric and the duodenal ulcer. So the patient will say that I eat something, I have severe pain. And it can lead to gastric carcinoma. So that's why whenever you find gastric ulcer, you have to take biopsy. Okay. And duodenal ulcer pain occurs on empty stomach, basically. Okay, so the patient says, whenever I sleep at night, I have pain. Okay, generally the patient gets awake during night, makes the patient awake during night. So this is the comparison between gastric and duodenal ulcer. Okay, and so these are the endoscopic findings. Look similar actually. So this is the duodenal ulcer, this is the gastric ulcer. Okay, and generally it will have irregular margins. So this is an important fact. If anything you find a tumor in the brain, you find a tumor in the stomach, you find an ulcer in the stomach, okay, or you find a tumor in the lungs, whatever, okay. If it has irregular margins, if it has irregular margins, it means there are higher chances it is malignant. If it has irregular margins, suppose like this, so that means it is malignant. Okay, until proven otherwise. So you have the patient has a brain tumor, so you go for CT scan with contrast that I will cover, means as we know from neurology. So you and you find that the patient has a tumor with irregular margins, so it means it is malignant. Okay, until proven otherwise. Okay, so this thing is important. So gastric ulcer will have irregular margins, and the patient can have various complications of these ulcers, like there can be hemorrhage. Most common complication of ulcer is hemorrhage. So the patient can have hematemesis or melena or hematochezia even. Okay, this is the most common complication, hemorrhage, or it can lead to perforation or penetration or even obstruction. Obstruction occurs when the ulcer it is at the pyloric end. Okay, so the patient will have repeated vomiting. So this thing also is important, but the most, if you are asked what is the most common complication, it is hemorrhage. Okay. The perforation can occur, it can erode the entire wall, and there can be spillage of the contents of the stomach leading to peritonitis. Okay. So what we will do, we will give the patient PPI. Patient has ulcer, we have diagnosed it by endoscopy because patient has these alarming features like melena or weight loss, anemia. So these are the alarming features. Okay, we did upper GI endoscopy, we find ulcer, we took biopsy, and it is free from cancer. Okay, we find gastric or duodenal ulcer, whatever. Okay, so we'll give the patient PPI, which will heal the ulcers. Okay, and if the patient is taking NSAIDs, we can ask the patient to stop the NSAIDs. Okay, if he can. Okay, we can take other drugs. So ulcer causes upper GI bleed, okay? They cause hemorrhage. So that will lead to increased blood bun level. That will lead to increased blood urea nitrogen levels. Okay, why? Because upper GI bleed. Because of upper GI bleed, there will be release of hemoglobin, which is a protein. So it will be converted into urea. So upper GI bleed leads to increased bun level with normal creatinine. With normal creatinine, okay. Steroid abuse also can cause a increased bun level with normal creatinine, okay. So there are various causes like we have increased bun level with normal creatinine. It is seen in case of upper GI bleed and also in case of steroid abuse. There can be causes of increased creatinine with normal bun level, normal blood urea nitrogen level. So this is seen in case of rhabdomyolysis. So increased creatinine level with normal bun level, it is seen in case of rhabdomyolysis and also in case of cimetidine use. Cimetidine, okay, which is a antihistaminic drug. Okay, Bactrim can also cause, I think, Bactrim can also cause increased creatinine. Bactrim is trimethoprim sulfamethoxazole. Trimethoprim sulfamethoxazole, okay. This is Bactrim. So Bactrim can also cause increased creatinine with normal bun level, okay. So we have increased bun level with normal creatinine. It is seen in case of steroid abuse and also in case of upper GI bleed, and increased creatinine with normal bun level. It is seen in rhabdomyolysis, cimetidine, or Bactrim use, okay. Clear? So this is for ulcers. Okay, next we come to stress ulcers. So stress ulcers mainly occur in ICU patients. Like the patient is on mechanical ventilation for more than 48 hours. The patient is a high risk. The patient can develop these stress ulcers. Okay. So these are various risk factors. So main risk factor is mechanical ventilation for more than 48 hours. Okay. Mechanical ventilation for more than 48 hours can also lead to pneumonia. It is a risk factor for pneumonia, okay, because the patient can aspirate, causing aspiration pneumonia, okay. Other risk factors also, this is the main risk factor, okay. If you are asked like the patient is in ICU or the patient has severe burns or the patient has paraplegia, so which of these patients require the prophylaxis? Okay, all of these patients require prophylaxis against stress ulcers. So in all of these patients, the patient has severe burns, okay, or had trauma, or the patient is undergoing neurosurgery, okay, or the patient has paraplegia, whatever, patient cannot move, patient is in shock, okay. So all these cases, in all these cases, we require prophylaxis against stress ulcers, okay, by giving the patient PPI. But only in case of like this is the most important risk factor. If you are asked what is the who of these require PPI urgently, or who is in the means require PPI for a very long duration of time, or which is the most important risk factor, then it is mechanical ventilation. This is a question also in few of the Q banks. This is the most important risk factor, mechanical ventilation for more than 48 hours, okay. So what is the mechanism of these stress ulcers? Stress ulcers, if once they occur, it becomes very difficult to treat the patient, okay. So that's why it's the best strategy is to avoid these stress ulcers when by giving the patient PPI when the patient has one of these any of these risk factors, okay. So this is how acute stress ulcer develops. This is the mechanism. You don't have to remember this for step 2, maybe for any other exam. If you're preparing, you can. So the patient is in shock, decreased cardiac output, and decreased blood flow, splanchnic blood flow that can lead to stress ulcer. Okay. Or there can be increased catecholamine release, or vasoconstriction, or the release of cytokines. So all of these cause decreased perfusion, splanchnic blood flow. So that will cause decreased mucosal flow, and that can lead to stress ulcer. Okay, clear? These are types of ulcer: curling ulcer, Cushing's ulcer. So if there is an intracranial pathology of tumor, or the patient has some brain injury, then it's Cushing's ulcer. Or if the patient has episodes of shock, okay, then it is Curling's ulcer. So the main cause will be decreased gastric blood flow, okay, due to whatever cause, splanchnic vasoconstriction, or due to patient is in shock, whatever, okay, or there is release of cytokines, whatever occurs, whatever may be the cause. The main thing is decreased gastric blood flow, okay, that will lead to formation of these ulcers. Okay, clear? So the most common cause of lower GI bleed, it is diverticulosis, and the second most common cause is angiodysplasia. So these are the diverticuli, as you can see. So these are finger-like projections, and they are mainly seen in case of sigmoid colon. So the patient has constipation. So they are the diverticuli. They are the most common cause of lower GI bleed. So the patient has constipation. So it will increase intraluminal pressure. So wherever there is weakness in the intestinal wall, there will be protrusion of these finger-like projections. Okay, and that will lead to diverticuli. So these diverticuli, they are false diverticuli, because all the layers means these herniations, they are not, they do not contain all the layers. Okay, they just contain the superficial layers only. Okay, so these are false diverticuli. So wherever there is weakness, means in that this time, because the patient has high pressure, patient is chronically constipated, patient has problem with his bowel movement, so the patient will have a patient is chronically constipated, so it will increase intraluminal pressure. So there will be herniation of these this mucosa and submucosa, okay, causing this diverticuli, which are false diverticuli. Okay, and suppose there is entrapment of some fecalith here. There is entrapment of this fecalith here and there. Okay, so that can cause damage to the artery, that can cause damage to the blood vessels. Okay, so that can lead to bleeding. Okay, okay, so the patient has constipation, patient has these diverticuli, and there is entrapment of a fecalith that will damage these arteries, and that will lead to bleeding. Okay, so that will cause lower GI bleeding. Patient can have melena, patient can have hematochezia. Okay, so what we will do is we will go for colonoscopy, and on colonoscopy we will find this kind of picture. Okay, finger like projections. So that's for diverticuli. Clear? Simple. Mainly seen in older patients. Mainly it is seen in older patients. Okay, and these diverticuli, they can get inflamed. Okay, so this is diverticulosis. Okay, if these get inflamed, the patient will have diverticulitis. Okay, so diverticulitis causes pain in the left lower quadrant, mainly occurs in the older patients with the chronic constipation. Okay, so the patient has this diverticuli, patient is chronically constipated, patient has older, like 65 or 70 year of age patient, and now he didn't report to the doctor, whatever. Maybe he has small amount of bleeding, so he didn't notice, and one day he comes to you with severe acute abdominal pain in the left lower quadrant. Okay, so that's diverticulitis. Okay, that's inflammation of these diverticuli. Okay, and the diagnostic test of choice, it is CT scan. We will not go for colonoscopy because the bowel wall, it is inflamed. Colonoscopy is contraindicated. Okay, because there is inflammation now in these diverticuli. If we go for colonoscopy, there are high chances we can perforate the bowel. Okay, so that's the diagnostic test of choice in case of diverticulitis, it is CT scan. Okay, in case of so older patient with left lower quadrant pain, it is diverticulitis, and the diagnostic test of choice is CT scan. If the patient is younger patient with right lower quadrant pain, that is appendicitis. Okay, and the diagnostic test of choice, again, it is CT scan. So young patient with right lower quadrant pain, it is again appendicitis, and the diagnostic test of choice here also, it is CT scan. Okay, clear? So in diverticulitis, we give the patient intravenous antibiotics. Okay, so which should cover gram negative and anaerobes. Okay, so always remember, this point is important. Whenever you have to deal with intestinal pathology, like the patient has a perforation of the intestine, or suppose, and you are you are going for surgery. Okay, so you have to give the patient antibiotics which cover gram negative and anaerobes. Why? Because these are the bacteria which are present in the intestine. So we have anaerobes and we have gram negative. So we give the patient antibiotics. Whatever intestinal pathology is there, we will give the patient antibiotics which cover these two organisms. Okay. So we give the patient like a combination of ciprofloxacin plus metronidazole. Okay, so cipro will cover gram negative, and metronidazole will cover anaerobes. Or we give the combination of like piperacillin tazobactam or ampicillin sulbactam, amoxicillin clavulanic acid. So these are all broad spectrum antibiotics. Piperacillin tazobactam. Okay, or amoxicillin clavulanic acid or ampicillin sulbactam. So these are all broad spectrum antibiotics which will cover gram negative and anaerobes. Okay. Also, we can give a combination. We can give cefoxitin plus gentamicin. So cefoxitin or cefotitin, these are second generation cephalosporins, and they are also broad spectrum. So they will cover anaerobes also and gram positive also, and also we can give with gentamicin. So always remember, aminoglycosides, they cover gram negatives like gentamicin, amikacin, tobramycin. So they all cover gram negative. Okay. So like the patient has infective endocarditis. Okay. So we give the patient combination of vancomycin plus gentamicin. So basically, whenever we are giving gentamicin, we are basically covering gram negatives. Okay. Patient has like meningitis. In that case, also we are giving these aminoglycosides because we want to cover gram negatives. Okay. Clear? So the patient has diverticulitis. Patient comes to you with older patient, 65, 70, whatever. Okay, he comes to you with acute abdominal pain, and pain is in the left lower quadrant. So the first step which you will go is a CT scan, and once you diagnose diverticulitis, you will give the patient antibiotics which cover gram negative and anaerobes. Okay, colonoscopy is contraindicated. But if the patient is young and if the patient has right lower quadrant pain, then it is appendicitis. Then also the test of choice is CT scan. I will come to that. Okay, so that's for diverticulitis and diverticulosis. Okay, clear. Next we come to angiodysplasia. So angiodysplasia, it is the second most common cause of lower GI bleed. So this is angiodysplasia. It is the second most common cause of lower GI bleed. It will so the patient has a painless abdominal bleeding. Okay, so we have to go for colonoscopy. So when we go for colonoscopy, we will find this kind of pattern, a fern-like pattern. Okay, so this is typical. This picture can come in the exam, and also that diverticulosis. And important thing about angiodysplasia, it is associated with end-stage renal disease and also iron deficiency anemia. Sorry, aortic stenosis. End-stage renal disease and aortic stenosis. Okay, so we have to rule out this renal disease by going for by checking the bun creatinine value. And also we can rule out some symptoms. If the patient has aortic stenosis, the patient will have symptoms like dyspnea. Okay, so we can go for transthoracic echo if the patient has symptoms. Okay, so end stage renal disease plus iron deficiency anemia, it is associated with which disease? End stage renal disease plus iron deficiency anemia, it is associated with which disease? Can you tell me? Any idea? It is restless leg syndrome. Restless leg syndrome. Okay, so we have end-stage renal disease plus aortic stenosis, it is angiodysplasia, and renal failure plus iron deficiency anemia, it is restless leg syndrome. That is neurology stuff. Okay, so this way you should be able to correlate the things. Okay, so angiodysplasia, basically it's a abnormal blood vessels. Okay, so what we will do is in case of this diverticulosis also, when there is a bleeding occurring. Okay, so we go for colonoscopy and we give the patient, we go for either argon plasma coagulation, APC, or cryotherapy. So if the patient has bleeding, so bleeding is because of the injured vessel, so we go for argon plasma coagulation, that will stop the bleeding. That will stop the bleeding, and also we can go for cryotherapy, or even we give the patient epinephrine. So cryotherapy or argon plasma coagulation, APC, or we can also give the patient epinephrine. Okay, this is the treatment. Clear? So this is for diverticulitis. As you can see, there is inflammation on the diverticuli. Okay, and we basically will go for CT scan. Okay, next we come to appendicitis.